Usually, when we talk about a medical diagnosis, there is this, I don't know, this underlying expectation of precision.
Right, like it should be exact.
Yeah, exactly. It feels like engineering. You break your arm, the x-ray shows a jagged white line, and the doctor just points at the screen and says, there it is. That's the problem.
It's very binary. I mean, the symptom and the root cause are isolated to that one specific area on the film.
Right. But the moment you step into the world of human intimacy and sexual health, I mean, that x-ray machine becomes completely useless.
Oh, totally.
We are looking at a diagnostic landscape that is, well, it's incredibly murky because a symptom in one person might actually be the direct result of a completely hidden condition in someone else entirely.
Yeah, and that's something a lot of people just don't realize.
Which brings us to the mission for this deep dive. Today, we are looking at a huge stack of sources. We've got urology guidelines, sexual health clinic reports, and these really deep gynecological studies on the vaginal microbiome and painful sex.
Some really fascinating data in there.
Truly. And we're using all of this to answer one specific question for you today. Can a partner's struggle to maintain an erection or, their struggle to delay ejaculation actually cause physical situational friction that gets misdiagnosed as a woman's own structural vaginal dryness?
It is such a critical dynamic to explore because, well, modern medicine tends to treat individuals in a relationship in these totally separate medical silos.
Right, like they aren't even connected.
Exactly. The man goes to the urologist for his performance anxiety,
Yeah.
while the woman goes to the gynecologist for her physical pain. But biology doesn't respect those clinical boundaries.
It really doesn't. Okay, let's unpack this. Because to understand the physical friction that causes that pain, we first have to, really understand the fluid.
The lubrication itself, yeah.
Right. The biology of how the female body physically prepares for intimacy is incredible, but looking at these sources, it is definitely not instantaneous.
Oh, far from it. It takes time. The biological reality of vaginal lubrication is driven by this highly specific chain of events.
Walk us through that, because it's not just, moisture appearing out of nowhere.
Right. So when arousal begins, the body responds to estrogen signals. And those signals trigger a massive localized increase in blood flow to the pelvic area.
Okay.
And that vascular congestion, it causes the vaginal walls to literally sweat moisture. The clinical term for this is transudate.
Transudate, like sweating, basically.
Essentially, yeah. Blood plasma basically filters through the vaginal tissue to create a natural protective layer of lubrication.
So the sources make a massive point of emphasizing the timeline here. This transudate process is not a light switch. You don't just flip it and it's on.
No, absolutely not.
I kept thinking about it like trying to drive a manual transmission car.
Oh, that's a good way to look at it.
Right. You can't just immediately shift from first gear into fourth gear while you're still sitting in your driveway. The machinery simply isn't ready for that kind of acceleration.
Right. You'd stall out.
Or you grind the gears. It takes several minutes of adequate, focused foreplay for that pelvic blood flow to build up and for the transudate to actually reach full effect.
Yeah, the vascular network demands that runway of time to engorge. And, what's fascinating here is that the stakes of rushing that timeline are much higher than just, temporary discomfort.
Because it's not just about comfort, right?
No, not at all. Natural moisture does far more than just prevent mechanical friction. It is literally the foundation of a highly protective biological ecosystem.
Okay, wait. How does moisture create an ecosystem, like a microbiome?
Yeah, exactly like a microbiome. In a healthy, estrogen-supported environment, the cells lining the vagina naturally shed. And when they do, they release large amounts of glycogen.
Which is a sugar, right?
Yes, essentially complex sugar. And that glycogen feeds beneficial bacteria called lactobacilli.
Okay, lactobacilli. Got it.
Right. And those lactobacilli then produce lactic acid as a byproduct, which maintains the vaginal pH balance between 3.8 and 4.5.
They get slightly acidic.
Actually, highly acidic compared to the rest of the body. And that acidity is a completely hostile environment for harmful pathogens.
Wow, okay.
So when a couple rushes past foreplay and starves the tissue of that natural transudate moisture, the environment dries out and the pH can actually rise above 5.
And that's when things go wrong.
Exactly. Suddenly commensal bacteria from the digestive tract, things like E. coli, they can move in and flourish.
Because the acid shield is basically down. So rushing past foreplay doesn't just hurt in the moment. It actually opens the door to chronic, painful issues later in the week.
Yes.
The clinical reports mention women getting severe urinary tract infections or bladder cystitis 24 to 72 hours after intercourse.
Yeah, it is a total ecosystem collapse, and it's triggered entirely by a lack of adequate preparation time.
That is wild. So if the female body absolutely requires this extended runway of time and stimulation to produce moisture, what happens when the partner is actively fighting against time?
Well, that's where things get very complicated.
Right, because the sources go deep into premature ejaculation, or PE. They cite that 20% to 30% of men experience this, but how do the urology guidelines actually define it?
So the clinical definition of PE is ejaculating within 1 minute of penetration. And sometimes, even prior to penetration.
Just 1 minute. That's really fast.
It is. And often, this is just a biological reality of how a specific man's nervous system is wired. They just have a naturally low orgasm threshold.
Meaning what exactly?
Meaning the neurological reflex to climax is triggered by very minimal stimulation.
Okay, so I read about the strategies men use to try and manage this on their own, and I have to push back a little here.
Okay, sure.
Because the sources call these arousal reduction techniques, and they paint them as universally terrible for the partner. But wait, if a guy is struggling with climaxing too quickly, isn't slowing himself down mentally the only logical tool he has in that moment?
It seems logical, yeah.
Right. Why are the clinical guidelines so against a guy, I don't know, doing multiplication tables in his head or using a numbing cream?
Well, from a purely mechanical, isolated standpoint, those strategies might delay his ejaculation by a few seconds or even minutes. Because, yeah, they reduce his physical and psychological excitement.
Right, like the numbing creams use lidocaine or something, right?
Exactly. They use lidocaine to dull the nerve endings.
Yeah.
But the problem is that human intimacy isn't an isolated solo event. These techniques are completely counterproductive to the partner's biological needs.
Here's where it gets really interesting and honestly kind of tragic for both people involved.
It really is.
If a man is actively trying to reduce his own arousal, like if he is mentally checking out to do long division and actively avoiding touching his partner so he doesn't get too excited.
He's withholding the exact thing she needs.
Exactly. He is simultaneously starving his partner of the escalating stimulation she needs for that transient process to happen.
It creates a catastrophic biological mismatch. Because he requires minimal stimulation to delay his climax, while she requires sustained focused stimulation to prepare her tissues for penetration.
They're on completely different timelines.
Totally different. So he eventually feels, safe enough to attempt intercourse, but because he's been withholding foreplay to protect his timeline, his partner is essentially still in first gear.
Right back to the car analogy. Her body hasn't had the time or the sensory input to sweat that protective moisture.
Right, leading directly to what clinicians call situational dryness.
Okay, situational dryness, meaning it's not a permanent condition.
Exactly. It's just happening in this specific situation. And when penetration occurs in this unlubricated state, the friction is immense. The gynecological studies describe this causing mechanical microtraumas.
Microtrauma, like small injuries.
Yeah, tiny tears and fissures in the introital mucosa.
Okay, let's translate that. The introital mucosa, what is that?
Sorry, yes. It's the very delicate, specialized skin right at the opening of the vagina. And tearing those tissues causes severe dyspareunia, which is the medical term for pain during sex.
Dyspareunia, got it.
Yeah, and it manifests as a sharp burning, tearing, or stinging sensation.
Wow, and a woman experiencing that is going to think, something is wrong with me. Why am I so dry? Why is this so painful?
Absolutely, she blames herself.
When in reality, her biology is capable of working perfectly. It just never received the required input because her partner was too busy doing math in his head to survive his own biological reflex.
Precisely. The man's low orgasm threshold dictates the pacing of the entire encounter, which then directly sabotages the woman's physiological arousal, resulting in her physical injury.
It's fascinating how that deep anxiety over timing doesn't just stop at premature ejaculation, though. The sources show it almost morphs into the exact opposite problem.
You mean erectile dysfunction?
Yeah, ED. The dread of finishing too early flips into the panic of not being able to perform at all.
It really does. With erectile dysfunction, the dynamic does flip entirely. It becomes an issue of vascular maintenance. A man with ED has difficulty achieving or maintaining an erection firm enough for intercourse, and performance anxiety becomes a massive driving factor.
The psychological panic described in these clinics is just intense. Instead of trying to slow down, a partner with ED is racing against a ticking clock.
Yes.
The moment they get an erection, they are terrified. They're going to lose it.
Right, and that fear creates this overwhelming urgency to utilize the erection before it subsides. The man's focus narrows entirely onto his own anatomy and maintaining that physical state.
Which means they rush. They completely bypass foreplay. They attempt penetration the absolute second they are hard, completely ignoring whether you, the partner, are physically ready for it.
They just have to go for it.
Right. Think about how isolating that must feel for everyone. The man is trapped in his own head, feeling this immense pressure to perform, while the woman is left completely behind, just subjected to painful, unlubricated friction.
It's heartbreaking. And if we connect this to the bigger picture, this rushed, frantic dynamic creates a devastating, self-fulfilling feedback loop for both partners.
A feedback loop. How so?
Well, when a woman experiences those repeated micro-traumas from rushed penetration, her body learns to associate intimacy with injury.
Oh, wow. It's classical conditioning, right? The body remembers the pain.
Biologically, yes. Her pelvic floor muscles will begin to involuntarily tighten and spasm in anticipation of the pain before intimacy even begins.
So she can't even control it.
Right. Clinicians refer to this hypertonic state as vaginismus, or levator anemyalgia. Her body is physically putting up a barricade to protect itself from further trauma.
So she physically tightens up defensively. And then the man with ED encounters this physical barrier.
Exactly.
He realizes penetration is difficult, he knows he is causing his partner pain, and that induces a massive spike in his own anxiety.
Which then triggers his sympathetic nervous system. That's the body's fight or flight response.
Right, fight or flight.
And when fight or flight kicks in, the body releases adrenaline. Adrenaline is a powerful vasoconstrictor, meaning it rapidly shrinks blood vessels, pulling blood away from the extremities to prepare the body for survival.
Oh, no. So it pulls the blood right out of the erection.
Exactly. That instantly kills the erection he was so desperate to maintain.
The very rush to save the erection is what destroys it.
Yes.
His ED worsens because of the pelvic floor tension that his rush timing caused in the first place. It is a vicious, closed-loop cycle of anxiety and pain.
It really is.
Which brings us to a major diagnostic dilemma. If a woman goes to her doctor experiencing the severe friction and burning, how does she know she's dealing with this situational dryness caused by her partner's dysfunction messing up the timeline, or if she is dealing with structural dryness like genitourinary syndrome of menopause or GSM?
That's the golden question. The clinical differences are actually quite distinct if you know what to look for, and making that distinction is crucial. Treating one issue with the medical tools meant for the other will fail completely.
Okay, let's break that down. Let's look at the structural side first.
Okay, so genitourinary syndrome of menopause, or GSM, is caused by a physiological, systemic drop in estrogen.
Which mostly happens during menopause, right?
Usually, yes, during perimenopause and menopause, but it can also be triggered by breastfeeding, or even medications like certain antihistamines and very low-dose hormonal birth control.
Okay, so the sources make it clear this isn't just a feeling of being a little less lubricated. The tissue architecture actually changes.
It physically alters, yes.
They mention fibroblasts becoming dormant and a loss of collagen. What does that actually mean for the tissue itself?
Think of healthy, estrogen-rich vaginal tissue like a thick, wet sponge. It's plump, it's elastic, and it has deep accordion-like folds called rugae.
Rugae, okay.
Right, and those folds allow it to stretch significantly without tearing. But when estrogen drops and those fibroblasts start producing collagen, that wet sponge turns into dry, brittle paper.
Ouch. That sounds awful.
It is. The rugae flatten out entirely. The tissue becomes smooth, pale, and incredibly fragile.
So how does a woman differentiate that structural change from a partner who is just rushing the clock?
The key indicator is when the discomfort occurs. Structural dryness from GSM is a chronic state. A woman will feel burning, itching, or irritation even outside of sexual activity.
So just during normal daily life?
Exactly. She might feel sharp discomfort just sitting at her desk, going for a walk, or putting on tight clothing. The tissue is always fragile.
It's an all-the-time feeling.
Exactly. Situational dryness, however, is entirely context-dependent. If the only time she experiences dryness, friction, or micro-tears is precisely during rushed intimacy,
Right.
and her tissues feel completely normal, stretchy, and comfortable the rest of the week, well, that strongly points to an arousal timeline mismatch.
Her biological machinery is fully functional. It's just being driven incorrectly.
That's exactly it.
So what does this all mean for actually solving the problem? Because the sources outline very targeted treatments, emphasizing that you have to use the right tool for the right underlying issue.
Yes. If the diagnosis is structural dryness, like GSM, the solutions must address restoring the tissue architecture itself. The guidelines recommend vaginal moisturizers.
And those are different from lubricants, right?
Fundamentally different, yes.
Yeah.
Use a moisturizer like a daily skincare routine. You apply it every few days, entirely separate from sexual activity, to help the tissues absorb and retain moisture long term.
Okay. What if it's more severe?
If the structural thinning is severe, doctors prescribe localized hormonal therapies, like topical estrogen creams or rings, to actually reverse the thinning and restore that acidic pH ecosystem we talked about earlier.
Okay, but if the issue is situational dryness, meaning the transudate process just hasn't had the necessary runway to activate, moisturizers or estrogen won't fix the immediate friction.
Right, they won't work fast enough in the moment.
In the moment, you need high-quality, water-based or silicone-based lubricants applied strictly at the time of intimacy to artificially replace the missing transudate and prevent those micro-traumas.
Exactly. And this leads us to the biggest paradigm shift in the clinical literature.
Okay, I'm ready.
Sometimes, the most effective medical treatment for a woman's situational vaginal dryness is actually treating the man's sexual dysfunction.
Which makes perfect sense based on everything we've talked about. If you fix his timing, you fix her friction.
Exactly.
If the root cause of her pain is his rush, medical science actually has incredible pharmacological tools to give that couple their time back.
We see this so clearly with the treatment options for premature ejaculation. Doctors can prescribe specific SSRIs, like duloxetine, which is sold under the brand name Prilogy.
Wait, SSRIs, aren't those usually for depression?
They are typically known as antidepressants, yes. But duloxetine was specifically formulated to act rapidly on the nervous system to delay the ejaculatory reflex arc.
So instead of the guy mentally checking out to do math and starving his partner of touch, the medication manages the neurological delay for him.
Precisely. That allows him to stay emotionally present and actually engage in the escalating foreplay she needs.
Okay, what about ED?
For erectile dysfunction, the PDE5 inhibitors, so medications like Viagra or Cialis, they're well known for increasing blood flow to provide a reliable erection.
Right, everybody knows those.
But the sources also highlight fascinating new over-the-counter options like Eroxon. It's a topical gel for ED that works in about 10 minutes through a rapid evaporative cooling and warming effect.
Oh, wow.
Yeah, it triggers natural nitric oxide release right at the source.
How does a 10-minute gel actually solve the woman's problem, though?
Because it completely changes the psychological dynamic of the entire encounter. By providing a reliable erection so rapidly, you remove the man's fear that the erection will vanish. You remove the panic.
He no longer feels the need to race against the clock.
Exactly. He can finally relax.
And because he isn't rushing to penetrate, the couple can actually spend 15 or 20 minutes engaging with each other. The woman's body finally gets the runway it needs.
Right.
She recognizes the estrogen signals, the pelvic blood flow increases, the transudate process kicks in, the pH stays balanced, and her natural moisture returns. By treating his underlying anxiety, you literally cure her physical dryness.
It beautifully illustrates that human intimacy is not a solo endeavor. Our biological responses are inextricably linked.
It really is a shared ecosystem. And that is the core insight we want to leave you with today. We started this deep dive talking about broken X-ray machines and how we tend to view medical issues as isolated individual parts.
Right.
But the reality is that intimacy is a shared chemical and mechanical environment. A male partner's mechanical struggles with timing or maintaining an erection directly and profoundly impact a female partner's chemical ability to lubricate and protect her own tissues.
Sexual dysfunctions do not exist in a vacuum.
They really don't.
And, this raises an important question, one that extends far beyond the pharmacology and the tissue biology we've explored today. We so often treat our medical issues as individual burdens, right? Hiding them away in shame from the people closest to us.
We suffer in silence.
Exactly.
Yeah.
But if one partner's silent, internalized anxiety about performance can literally, physically alter the other partner's cellular environment and pH balance, how might radical, vulnerable communication outside the bedroom be the most potent medical intervention of all?
If you can just talk about the grinding gears before you get in the car, you might save the whole engine. Thank you so much for joining us on this deep dive. Keep questioning those hidden connections in your own life, and we'll see you next time.